I had a talk with a friend that my 35-year-old was out in space just wants to be a dad, avoid having to take care of her.
All right, so I think most people have come back. Okay, Vicky's coming back, so maybe I'll wait for her to come in.
I want to say something.
Whoa! And she made an entrance.
We were just waiting for you to come back to start.
Okay. All right. So, hi everyone. So, I'm Aravna Simpson. I'm a pediatric hematologist oncologist in Ottawa at CHEO, for those of you who don't know me. And this evening, I have the privilege of presenting with Dr. Madeline Verhofstadt, who is a hematologist and hemoglobinopathy lab expert from McMaster Adult Hospital. I was going to say Children's Hospital. I'm so used to pediatrics. Anyway, so the two of us were going to be talking about understanding privilege, bias, and allyship, but specifically in hemoglobinopathy practice. And so it's something a little different. It's not very medical. However, it's something that's very relevant to our practice, where we care for many individuals who come from racialized and stigmatized populations. So we wanted to start off by acknowledging that we're on a territory known as Treaty 7, which is a treaty that was signed on behalf of Queen Victoria in 1877. And so there are three First Nations that reside in this territory: the Stoney Nakoda, the Blackfoot Confederacy, and the Tsuut'ina Nations. And so we're grateful that we are able to be on this land and to appreciate and benefit from the tremendous beauty that's here. So these are our disclosures. And so we don't have, we didn't have many disclosures, but we do have a disclaimer. So bias and privilege are difficult topics and can be potentially traumatizing to talk about. And so the goal of this session today is not to lay blame on anyone, but just to acknowledge the lived experience of those communities who are marginalized and to validate that experience, and hopefully to give you ideas about how best to approach allyship, bias, and privilege in your day-to-day practice. So we have 4 learning objectives. So we hope that by the end of the session, you'll be better able to describe the relationship between social identity and privilege, and that you'll also be able to define bias and recognize where it exists in our practice, and also that you'll be able to understand allyship. So this is a really critical concept because it helps us to be active supporters and advocates for our patients who confront these issues. And so that ties into the last objective, which is to apply these concepts to our work as hemoglobinopathy healthcare professionals. So I wanted to start off by talking about social identity. So as you see defined on the slide, social identity is the perceived membership within certain social groups based on specific physical, social, and/or mental characteristics. So we all have social identities. And so when you think about social identity, it could be something that's dynamic, it could be something that you choose, something that you're born into, it could be something that's visible or something that's invisible. And it could be static or it can change depending on the context that you're in. So when thinking about the hierarchy of social identities, these are defined by society. And so the ranking of the groups and specific differences and their importance is determined externally. We don't decide that for ourselves. Each of us will have multiple social identities, and they actually connect and interact with one another. So I'll talk a bit about that, but they'll interact in different ways. And then the importance of a specific social identity can really depend on the context that you're in or the situation that you're in. So I wanted to give an example. So race is an example of social identity. So here in this photo, you have 2 young women, Lucy and Maria Aylmer. So they come from Gloucester, and they say that when they walk down the street, people often confuse them for being friends, but in fact, they're twins. So Marcia and Millie Biggs are also twins. Their father is of Jamaican descent, and their mother is of English descent. Similarly, James and Daniel are also twins. So this is really fascinating, and when you think about it, each one of these individuals will see society or encounter society from a different perspective because of the way that they're phenotype contributes to the way that society treats them. So I give these examples to talk a little bit about how race and social identity can be fluid and change over time. So this slide on the right basically talks about how your racial identity can change depending on the context. So for any one individual, their racial identity can differ from what they depending what they classify on a survey, how they look phenotypically, how you perceive them from the outside, and these will all impact the way that they're treated. And so this survey here just basically looks at multiracial individuals from the United States, and they see, like you see in the top, basically 29% of individuals who previously thought of themselves as one race changed depending as a result of their interactions with society to feel that they're actually more than one race. And vice versa, the corollary was also true. So whether we choose them or not, our social identities will come with varying degrees of power and privilege. So this colorful wheel is adapted from Sylvia Duckworth's Wheel of Power and Privilege, and it attempts to contextualize how our social identities affect our level of privilege in society. So if you look at the center of the wheel, this will represent the highest positions of power and privilege. But the further your social identities are from the power center, the more marginalized that you'll be. And in most cases, when you think about those identities that are closest to the center, these are the ones that you probably don't have to think about on a regular basis. So for example, when you walk into a store, you probably don't think much about the fact that you're a physician. But for myself, sometimes if I walk into the store, I'm very aware of my race and how I'm perceived by the shopkeepers and the owners of the store. So you can see how this tool can be used to reflect on your own position of power and privilege in society, but it's also helpful to reflect on that of your patients, of your colleagues, your family, your friends, and it helps us to understand where we're coming from and the privileges that we bring to any given context. So what exactly is privilege? So privilege is defined as a right or benefit that's given to some people and not to others. And by definition, it's something that's unearned. So privilege is not the same thing as being spoiled, okay? So being spoiled means that you have an individual level trait or an impaired character because you're excessively lavished upon, praised, or indulged without actually recognizing it. So that's not at all the same as privilege, but it's important to recognize that privilege is a systemic advantage that benefits one social group over another group. And so when you think back to our social identities, many of us will have aspects of our social identities that offer privilege, but others that make us relatively underprivileged. So I'll just skip ahead from this one. So I wanted to talk about a concept called intersectionality. So it's a term you've probably heard. It was coined in 1989 by a Black lawyer and scholar by the name of Kimberly Crenshaw. And basically, it refers to the way our social identities will interact and compound to influence the way that we're seen by society and influence our opportunities that we will have. And so you see this quote here. It was Audre Lorde, who was an American feminist, writer, and civil rights activist, who first said that there's no such thing as a single issue struggle because we do not live single issue lives. And so this is really important for us as healthcare providers because we shouldn't be taking a unidimensional approach to care because each one of our patients will have different social identities that'll impact their abilities to access care and opportunities. More of the same. So I really like this particular cartoon. So basically, it's a cartoon that attempts to demonstrate the differences between inequality, equality, and equity. And it's based on the book, The Giving Tree. So in this image here, you can see that we live in a world where the giving tree is actually crooked. And so as a result, we don't have equal distribution of or access to opportunities. So equality means that we give everybody the same tools and supports. But as you see, it doesn't necessarily mean that each person will have access to those apples or opportunities. Equity implies that we give everyone the tools that they need to get those opportunities. So you can see we provided the person on the right with a taller ladder, but we haven't corrected the problem. That tree is still crooked. So the goal is actually to achieve social justice and to straighten the giving tree so that we all have equal access to opportunities in society. So coming back to this wheel of power and privilege, having privilege is not necessarily a choice, like I said, because you can't choose your social identities or how you're perceived by society. But by recognizing your privilege and the opportunities it brings, it'll make you more able to be an ally and to address disparities in society to help our patients and our colleagues to have equitable access to opportunities. And so this is a brief video. Hopefully it works. Nope, video not available. Okay, so that's okay. So this was just a video clip that was showing different examples of stereotyping and bias that lead to difficulties in accessing opportunity, and many of which were relevant for our patients. So it's unfortunate we can't see it, but in any case, I want to take you through a short exercise. So in the literature, it's suggested that it only takes 7 seconds to form a bias about somebody or something. So I want you to take a look at this individual, and you don't have to say what you think out loud, but if you came across her, is she somebody that you'd hire to be part of your medical team or a research assistant, or is this somebody that you would leave your children in the care of based on this 7 seconds impression? So she could be your attending physician actually, and this is Dr. Sarah Gray. So she's a surgeon from Adelaide, Australia, and she frequently encounters bias and poor treatment as a result of her many tattoos. When she enters restaurants, she's been refused entry. When she goes to stores, she's often followed as a result of her appearance. And how about this gentleman? What do you think about him? Some of you may know who he is. Now compare him to this image here. So this photo here on your left is of Brian Sinclair when he was 45 years old, and he presented to the Winnipeg Health Sciences Emergency Department to have a urinary catheter changed. And he was left there by the staff to seek medical attention. And he basically sat there and sickened and died over a period of 38 hours while staff saw him and assumed that he was, because he fell asleep, he was drunk, that he was homeless, and no one actually attended to him as a patient. And so the picture on the right is not of Brian Sinclair, but it could be what he looked like when he was sitting in that emergency department, while people let their biases prevent him from getting the care he needed. So this is something that you may already know about, but cognitive bias basically is a large category of biases that lead to repeated patterns of thinking that are basically shortcuts for us to make quicker decisions, especially in situations of stress or in medicine when we have to make rapid decisions that could be life-saving. Unconscious bias or implicit bias is something that we can't perceive that affects our behavior, interactions, and decisions based on storylines that we have formed based on our previous experiences. Okay? And unconscious bias influences us as physicians to provide different levels of care to patients depending on those biases. So I don't know if you're aware of System 1 and System 2 level thinking, so I'll just go through this quickly, but basically when we talk about System 1 level thinking, so these are the shortcuts that we take to make these rapid decisions. They're innate, they're difficult to overcome, and they tend to be intuitive, fast, and irrational, and they lead to many different types of bias in clinical medicine, including unconscious bias. And unfortunately, as a result of these biases and shortcuts, it's been shown over and over in the medical literature that they lead to errors, which can lead to patient morbidity and patient mortality. So when we think about System 1 level thinking, these fast, automatic, and intuitive decisions, they tend to be error prone because we're not using analytical type of thinking. We're not filtering information to come to these decisions. And interestingly, they make up about 95% of the type of thinking processes that we actually have. when we talk about system 2 level thinking, those are the thoughtful, slow, and rational thoughts that we go through when we actually take that information and analyze it to make logical decisions. And this only takes up about 5% of the types of thinking that we actually execute. And when you think about how this impacts clinical care, there are a number of examples. So for example, it's been shown in the literature that white male physicians specifically are less likely to prescribe pain medications to Black patients compared to white patients. Similarly, it's more frequent that physicians will assume that Black or low-income patients are less intelligent, are less likely to follow directions, and more likely to engage in risky behaviors. So of course that's going to impact the efforts that you make in terms of guidance and management plans that you make with those patients. When it comes to pregnant women, it's been shown that pregnant women will face discrimination from healthcare providers based on their ethnicity. And so you've probably all seen news stories recently related to increases or higher maternal mortality in the Black American population compared to other non-racialized populations. In Canada, we don't have this data, but there's suggestion that it's similarly dire in terms of the outcomes. And then when thinking about the elderly and ageism, physicians are less likely to treat suicidal ideation and mental health issues in the elderly, despite the fact that we know that in populations of patients aged 85 and older, they actually have higher rates of suicide than younger age groups. So we all have biases and none of us are immune. And the truth is that the only way to overcome these biases is by being conscious and thoughtful about mitigating these biases and reflecting on what biases we have and how they play into the care that we deliver and the way that we evaluate our patients. So, okay. So this was just to change gears a little bit and to take you back to a time when I was a resident. And so I was on call, I was a senior resident, and I was working with a medical student who happened to be a tall white male. And so we were in the emergency department admitting a patient, and so we were reviewing the plan with the family. And it became very clear after a short amount of time that the family was not engaging me. So with every attempt I made to speak directly to the family, they direct their eyes to the student and ask him the questions. And so I tried to redirect, but to no avail. And the student, you could tell, was a bit uncomfortable. He's not sure what was going on, but he tried his best to answer their questions. And something that was interesting and disappointing was that the emerge physician was standing there throughout this encounter and didn't say a single word. And so for me, my confidence really took a hit after that because I couldn't understand what had happened. You know, I felt like, you know, I knew what I was doing. I was more trained than this medical student, but regardless of what I did, this family completely did not acknowledge that I was in the room. And so I asked myself, was it related to my race? Was it because I am female, because I was young? And, you know, of course I came to no reason, and at the end of the day, it didn't really matter, but it really did have a big impact on me and my confidence. And so this here is just to emphasize the importance of language when we talk about our patients in the emergency department, whether it's on the floor, in a room, outside a room with colleagues. But these are words that we often hear, sickler. You know, even with education throughout the hospital, I still hear healthcare providers say it, and now I'm less shy about correcting them in the moment because for our patients, we know that this is offensive and derogatory. No-shows, talking about how so-and-so has no-showed X amount of time, or when I'm in sickle clinic, it's happened where I've overheard some of the clinical staff talking about, oh, you know, it's sickle clinic, nobody's, you know, people aren't going to show up. And so that influenced the way that you see that clinic. But also, you need to think about why is that individual not showing for their appointments, because there are likely barriers that we can help them to address. Single mother and the stereotypes that go with that. Absent mother, she's not at the bedside and her son's been admitted to a hospital. Again, what are the reasons? Why is she not there, rather than judging? they're non-compliant, they don't listen, they don't take their medicines, they're drug seeking, they don't really have pain, or they're difficult. All of these labels impact the way that we see our patients and how others see them and the way that they're cared for. So it's up to us to really stand up and try to confront these generalizations and stereotypes. So this is a powerful image that Dr. Verhofstadt had shared, and it really makes you think, going from pediatric to adult care with our patients. So when is it that a Black man or a Black boy or a Black child becomes a threat? Looking at them, what is it that changed over the course of time? And this is something that unfortunately is a harsh reality in our society. So I come to you to talk about how allyship is our way to be an upstander and really to advocate to protect our patients and our colleagues and all those who come from marginalized social identities to be able to access the same opportunities in society. When you think of your colleagues and your patients, they come from a mosaic of differences, and it's really important to know how to respect that difference and to accept it. And so I'm going to read a quote because I think it really simplifies what we want to achieve with allyship. So allyship is about having someone's back. It's an ongoing process of advocating, supporting, and being a voice for those people who aren't being heard. So this means that allyship is not just about saying, I'm not racist, I'm not sexist. It's actually active. It means that you actually have to counter these messages, these negative messages, these disparities in treatment and outcomes, and it's about being an upstander, not a bystander. So practically speaking, how can we achieve that? So firstly, we have to listen more than we speak as allies. So that means that in working with diverse patient populations, we actually engage with those populations and try to understand the barriers that they are going through and see how we can recognize and help to address those barriers. When talking about our trainees, we should engage with trainees and faculty across social groups. And that helps us to develop counter stereotypes about those groups, but also helps to elevate those who are marginalized as leaders, educators, and preceptors. We also need to embrace these uncomfortable conversations. I think there was a time where it was very taboo to talk about these things, but we know that the only way to address them is to actually acknowledge them. And so as an ally, if you're having these conversations and not feeling uncomfortable, you're probably doing something wrong. And so really, it's important to be okay with that discomfort and know that along the way we're going to make mistakes, but together we can move forward and be effective allies. So one thing that's challenging and important, though, is not to continuously ask those who are underrepresented to be your teachers. And so there may be some who are inspired and passionate about this area and want to do it, and that's wonderful. But really the responsibility for education falls on ourselves. And really it's important for us to seek that knowledge and to work on building our skills as allies. We need to recognize that our needs are secondary when we are allies. It's not about us, it's about those people we're supporting. And that also means that we do it without any expectation of recognition. We're not saviors, we're supporting our peers so that those who don't have voices can be heard. Again, it's not about us, so you should be an active ally without expectation. So the second step to becoming an effective ally, or second part, is about that reflection. And so we talked about that wheel of power and privilege. Another important aspect of reflection is cultural humility. And you may have heard this term, or cultural sensitivity, cultural curiosity. And so this is something that's very different from cultural competence, because it's impossible to be knowledgeable about every culture, right? But I think having that curiosity, wanting to know more, wanting to understand, wanting to engage, is what helps us to be better allies and to really become more aware of the barriers that those around us may face, those with less privilege. So again, this is a tool that's also very useful in reflecting on your position of power and privilege, but it's also helpful to think about the people you surround yourself with in your circle of trust. What are their positions of power and privilege? Do you have a diverse circle around you? And how does that impact your understanding and your biases when you encounter people who are different from you? So it's really important for us to really reflect on where we stand and how that impacts our patients, and also where they stand and how that impacts their access to excellent care and better outcomes. And finally, the last step in becoming an effective ally is growth. And so that's something that comes over time. And so you may or may not have seen this before. It's a conceptual framework for becoming anti-racist, but it also applies in general to becoming anti-biased or mitigating your own bias, and I adapted it a little bit for that. But basically it starts from a place of fear and discomfort, right? Where you really don't know if you're doing things right. It's not really clear how to approach a situation. But then with that self-reflection, that self-education, and that real desire to want to be a better ally, you'll gradually move from that fear of discomfort to that area of learning and eventually growth, to growing into an effective ally. And so that's what I wanted to cover. And so just a few take-home points. So we talked about how we all have interconnected social identities, and that each one of us has some social identities that will give us privilege and some that will make us oppressed. And we all have unconscious biases, and these biases and stereotypes negatively impact clinical care, as well as our interactions with our students in teaching, and will, as a result, impact outcomes for our patients. And so we should actively counter these stereotypes by trying to be effective allies and becoming better upstanders for our patients. And so the positive spin to all of this is that as allies, it is actually possible to change these social disparities and inequities, as cynical as many of us had become over time. I truly do believe in this work, and that it's possible for us to eventually create a society that's more just and equitable for everyone. So that's what I wanted to cover. And so I'll pass it over to Dr. Wilcox. So any questions or comments? I don't want to just speak at you. Yeah. Yeah, like, does this seem like something that is very theoretical or actually feasible? Or
actually probably one of the best presentations I have on that, despite having been mandated to take many
okay.
inclusion through our health associations. Like, it was very well done.
Okay, thank you. Thank you for that. I hope it's helpful, because I think the goal is to leave here with skills or tools, right? So at least, hopefully, it at least points you in the right direction.
Excellent. I actually, I consider myself very in touch with that part of myself, because I'm, doing the clinic all the time. But I didn't realize that, calling someone non-compliant and discussing their non-compliance without the full context, could be perceived as, and negative. And I think going forward, I would, talk about the non-compliance, but with the full context of why. As a better way to kind of educate students.
Mm-hmm. Yeah, I think it's really important.
You've got to figure out why.
Mm-hmm.
I mean, we need to talk about
I think bottom line is we need to talk about adherence. Adherence is a major. Why are you giving someone medication if they're not going to take it, right? Mm-hmm. That's the bottom line. But figuring out why, I think, is important. And I think that's my take-home message, I guess, from what you're saying is that we don't often think about why. We just go directly from seeing it and then acting right away, and almost like a reflex, mm-hmm. and not reflecting on it.
Mm-hmm. Yeah, it's true. I think we all do it because we're busy. So sometimes.
And we were taught to do that in
mm-hmm. medical
school, day one, right? I mean, we talk about is a recursive Bayesian loop essentially, mm-hmm. right? Pretest probability, like we look at something, we see something, we observe it, we generate a pretest probability that feeds into our brain, and then we generate a post-test probability, we feed that back, and then it keeps going into this loop.
Mm-hmm. Yeah, that's true.
Do you have any tips about dealing when it comes from patients and is directed at healthcare providers? That we encounter a fair amount, not just in clinic, but in the hospital and everywhere else. And I always find it a bit easier if it's my trainee that I'm defending, but it's a little hard and how to redirect. Do you have any tips for that?
Yeah, so it's a really great question. So I guess some of what I have developed as my toolkit for this is related to dealing with microaggressions, and I think one of the most powerful things is to actually reflect that comment back to the person, make them think about it, make them feel the same discomfort as you feel when they say it, right? Like they say something like, oh, you people are often this way. What do you mean by that? Or, I don't understand why you're saying that. Or it sounds to me like you have negative feelings about this. Like, tell me more, and then, reframing it for them, but also challenging them a little bit so that they have to reflect on it, I think is really helpful. And it's difficult because sometimes, depending on the situation, it may not be most appropriate to do it right there and then. Like maybe you have to take a step back and think about it and then like really, pull yourself together too so that you have your plan and your approach. But often actually, it's best to do it in the moment if it's a safe environment and it's a person that you can speak to without fear of reprimand or fear of retaliation or anything in the moment. But I think that reflecting it back to them is really powerful. Okay. No problem. Yes, I know what you mean. Yeah, it's true. Yeah, it's true. And often, and maybe this is me being naive, I don't think that most people will say these things with ill intent necessarily, so that reflecting it back to them will make them take a pause, like, oh, that's how it sounded, like, oh, that's how it came across, Yeah.
Quick comment. Sorry, go ahead. I've talked a lot already. Go ahead.
Thank you for this. I really enjoyed it. But I was just wondering, in a practical sense, how have you been able to effect change, beyond pediatric hematology oncology? Because that's, I think it's somewhat less of a challenge within my division because I know the people. So I can address things when I hear, she's late again for her appointment and things like that. But it's beyond, right? I hear of it, in other areas within our hospital. And so practically speaking, how have you been able to affect change in those areas?
And so that's a nice segue for Madeline because she's going to talk a lot about that systemic level advocacy that we can do. But, just briefly, in our context, a lot of it has to do with education. So, I have my sickle cell presentation that I do and embed anti-racism within that, and I speak to the emergency department. I speak to general pediatrics, and I think it's really important to embed it, like not just for those faculty level discussions, but also for our learners. So, it's difficult for one person, so you really need to have engagement and allies in helping you get that message out. And I think that because of many of the events of 2020, the impact of COVID on racialized communities, George Floyd's murder, all of these things have made us more aware. So it's a bit of a window of opportunity where there's institutional buy-in to really make meaningful change. So, sometimes we have to be a bit opportunistic and take advantage of that to really get the message shared. Yeah. Does that answer your question? Yeah? Okay.
I was just going to mention, I liked how you were listing the steps to how to become an ally, how to be an ally, listen and some other components. I found what helps in my clinic is when I'm meeting someone at their first visit, I acknowledge with them the institutional racism that exists. Like I just tell them, listen, when you come to the emergency room, this is what to expect. And because you are Black, there might be some, unfortunate systemic racism we have. You have to, advocate for yourself. Here's the sickle cell disease card. These are the tools we have in clinic to help you deal with this. We know it's happening. We're working behind the scenes to fight it. But I find that acknowledgement, like people just relax, that they realize, we have allies within, and that seems to help.
Yeah, that's important. I think that's powerful too, because I think, living with that experience, having someone acknowledge that they know you have that experience, I think is really important and helps to empower them to know that at least there's someone they can turn to for support. So I think that's a really good approach. Yeah. Okay. All right. Thank you. Okay. So Madeline's going to take over. Okay. Thank you. And it's just forward, backward.
And Yorabina's not going anywhere, so if there's more questions for her, and feel free to stop me at any point as we're going through this. Okay. So exactly as we had said, this is kind of just jumping off from and building on the content that Yorabina has gone through and speaking to specifically racism in healthcare and even better, anti-racism in healthcare, where we're looking to reshape the system through advocacy and education. And as has been brought up in some of or alluded to in some of the questions and discussion here, this is perhaps for many of us working in hemoglobinopathies most important for our patients with sickle cell disease. Everybody here knows about the pathophysiology of sickle cell disease and the broad complications it can cause in terms of the lifelong anemia and the episodes of pain. And many of you have probably seen this illustration and others from this series. These were done by an artist named Hertz Nazaire, who unfortunately just in this past year passed away. And he was an artist of Haitian background living in the United States, who was living with sickle cell disease and who created images to try to express the feelings that could only be conveyed through images and couldn't be conveyed through words. And so as we think about our patients, especially when they're coming in with these episodes of excruciating pain, we recognize as well that most of them most people living with sickle cell disease worldwide, and in fact, people living in Canada with sickle cell disease are going to be Black or racialized, many of them coming from African ancestry. And so then the intersection of that very challenging, complex chronic disease with terrible acute episodes intersecting with their identity, their racial identity. And so many of you have seen this illustration, and in fact, Yorabina had reflected on her sickle cell disease talk that she brings out for the various audiences, and this is in every single talk that I give about sickle cell disease, whether it be for our emergency department staff or trainees. And it's looking at the barriers to care for patients with sickle cell disease, and there are many, including the ones listed, and standing out for us today is this kind of vicious cycle that includes racism. And it's an aspect of the patient's experience that they can't control, right? It's just a part of their personal identity. Some things we can change, a clinician or a patient knowledge deficit we can work on. Frequent visits, we can do all we can with disease-modifying therapy and comprehensive care. Again, through education, we can try to address the stigma and these issues of chronic pain and perception of addiction. And I guess I'm putting forward in today's discussion that education and advocacy and allyship are going to be part of addressing the racism part of this cycle too. So this was something that came out in Ontario, and it's kind of beyond the scope of what we're going to talk about here, about the content of it. There's in fact a follow-up initiative happening in Ontario right now looking to establish provincial standards for sickle cell disease. And so, the main medical crux of this initiative was the flow diagram and the many pages of evidence-based guidance that were embedded in it. But for me, being part of this, more important was the weaving through this 100-page document of patient and family member experiences in these blue boxes. And so this is just a screenshot to kind of give you a sense of what was there. And there's been lots of qualitative research looking at what the experience is of someone with sickle cell disease. But this was kind of a unique opportunity to look like right in Ontario, what are our patients experiencing, and juxtapose it side by side with what should be the care that they're receiving. So I'm just going to show you a few, to me, kind of very poignant quotations from the focus group that was done. It's a fear of how you will be treated. I'm afraid I will be sent home when I don't feel well. It's a longer one, so I'm going to read through it. My brother was 33 years old when he went to ED with a crisis. They saw a black male and told him he was looking for drugs and not having a crisis. Despite that comment, they gave him 40 Dilaudid and sent him home. I called him and told him I would go over the next day as he lived alone in an apartment. My aunt called in the morning and told me not to come. They found him dead. He had a pill sitting on his tongue. When you're in a crisis, you don't know what's 2 hours or 4 hours. And this last part is in reference to wondering, I think, whether he may have unintentionally overdosed on the pills that he was sent home with. There's a visual disconnect. You're not bleeding or broken. Quote unquote, ED is for emergencies. It is an emergency. That is why I'm here. Yes, I look this way, but you cannot see my pain. So again, looking at this intersection of the patient's identity, often kind of outwardly looking very well, young, maybe. And again, where that race intersects with it, and the fact that there's this invisible pain that someone is having to justify. And we're going to come back to this again in a second with a non-sickle cell case that I'm going to discuss. This is the last or second last here. Speaking of black male, when I had my first major crisis as an adult, I fell into a major depression. I've been to the ED and been told I wasn't having a crisis. They didn't believe me until I threw up on myself. It turns out I had a blood clot and the vein was twice the normal size. One time I pushed the call bell 50 times in 2 hours before they came. One time I was yelling for help and they called security, and security threatened to call the cops because I was irate about a lack of care. And so this was an illustration that I put together because when I'm in clinic or when I'm hearing stories like this from patients, this is the best depiction of what I envision in the worst parts of their journey, the journey feeling like for them, where they have these health challenges that are an enormous burden at times, not always for everyone, but in these worst moments. And where not only are they having to push these health challenges, but they're having to do it uphill over rocky terrain as a result of racism, health inequities, and system barriers. And so we're talking a lot about sickle cell disease and an emphasis on anti-Black racism. Irabana had shared an example of Brian Sinclair and the injustice he had experienced and loss of his life as a result of inattentive care. And this was a similar one. And this happened, around the time of George Floyd's killing. Joyce Echequan in Quebec, who had actually filmed and documented the taunting and slurs that she endured in a Quebec hospital before she died. Mother of many, young children, a lot of people depending on her. And then these are high-profile instances from the United States, but I think we can learn a lot from them here in Canada too. Two intelligent, knowledgeable women. On the left, Dr. Susan Moore, who was in the hospital, and this is a screenshot from a selfie video that she had taken of herself in the hospital, explaining how her symptoms were being diminished, how she was being threatened with being discharged from hospital, how she was having severe pain that was not believed, that was not treated, until they did a scan and saw that she was having, lymphadenopathy in her neck and new changes in her lungs, how she didn't get the full course of remdesivir for her COVID illness, and ultimately was discharged from hospital and died at home just a few weeks later. And so putting this side by side with a very high profile athlete that many of us, probably most of us, recognize, just recently retired, Serena Williams, tennis star, who had a history of thrombosis and who immediately postpartum developed symptoms that to her, she was concerned about that she might have a PE, and was trying to get the attention of medical staff and was dismissed. And the diagnosis might have been missed if it were not for her strong voice and speaking up for herself. So why I show these two examples is thinking, if this physician on the left, whose peers are dismissing her, who knows exactly what the treatment is for COVID and knows exactly what's happening with her body and what the standard of care should be, who knows how to advocate for herself, can't get the care she needs. If this greatest of all time tennis player who's had a clot before, knows what it feels like, is trying to advocate for herself, wealthy, tremendously wealthy person, right, is not able to get the care. If these two people are not able to get the care that they need, what does that mean for the average person? What does that mean for someone whose identity, they are experiencing bias in the healthcare system because of their identity? So, bottom line, and at the risk of oversimplifying it, as healthcare workers, and I know I'm preaching to the choir here, we're all there for our patients, but I feel this as like an extra weight that trying to even think about how I can go above and beyond on behalf of my patients and that advocacy. And this is a friend of mine. This is Lyndon George. We met when he was seeking to share his experience with the healthcare system in Hamilton, where I practice, about where he was dismissed and didn't receive the treatment he needed for what ended up being a recurrent pulmonary embolism, a thrombosis. And I do thrombosis as it's one of my hats, right? He's not my patient. We weren't involved in care, but he sought me out and thinking, how could he help to affect change in the healthcare system? Cool story. Lyndon has now gone on to be the executive director of the Hamilton Anti-Racism Resource Center, where he's now got an even stronger platform to partner with healthcare workers or partner with organizations and hospitals to try to bring about that change. So it's kind of an illustration that the problem is close to home, but some of the solutions can be close to home too. And again, we're using these examples from the United States, but just highlighting that anti-Black racism is an issue not just in the States, not just in Hamilton, but across Canada. And a generation of advocates are rising up and speaking up. I'm going to read another kind of passage, I guess, here. And so the title of this article, this was published in The Lancet in 2020, Moving Toward Anti-Racist Praxis in Medicine. It's not enough for burgeoning clinicians to know the body inside and out. They must also know the historical body of work about enduring medical practices based on exploitation and/or exclusion and long-standing medical policies that render certain populations sicker than others. Such knowledge informs their structural competency skills development. For the same reason, new and established physicians must undergo consistent continuing medical education that includes anti-racist structural competency training. Such level training makes for better doctors who are well prepared to address the needs of a changing nation and changing world. This is what medical education, justice, and practice should look like. So building upon what Yaravana had shared with us, I think there's no secret recipe for allyship, but sometimes you'll hear this term critical allyship. And it's kind of thinking about how we can be very intentional about our allyship. And I like the word solidarity here. So there's this, we trimmed out some of the slides, so that's where the reference to the coin. There's something, and look it up, there's some neat, very concise, it's good for kind of bringing awareness about privilege. There's something called the coin model of privilege. Stephanie Nixon, who was formerly a rehab faculty at U of T, who's now moved on. She's the Associate Dean of Rehab and Medical Sciences, I think, at Queen's University. So she came up with this model, and there's some nice videos kind of illustrating it. And it talks about how anything where there's privilege on one side, there's somebody who's going to be oppressed on the other side. There's going to be somebody who's marginalized because of the opposite identity, right? If we think about white, non-white, cisgendered, non-cisgendered, etc. So number one is operating in solidarity, and I love that word. Another word that I kind of try to aspire to is being a co-conspirator, right? So where you're not just ally and like aligning yourself with someone, you're actually working together, like how can we fix this together? What problems are you having? How can I, and again, doing so in a way that doesn't seek to be recognized, doesn't seek acknowledgement or limelight about it. Number two, learning about systems of inequality. Number three, stepping back. So kind of, again, that listening and really playing a supporting role. Number four, focusing on changing systems where we see that work that needs to be done. And just, I guess this is emphasizing over and over again, allyship does not equal power. And so health advocacy is such that healthcare professionals responsibly use their expertise and influence to advance the health and well-being of individual patients, communities, and populations. I'm going to go through, this is going to be pretty quick. So when we think about anti-racism, sometimes you hear anti-racism, anti-oppressive. What does anti-oppressive mean? I don't know if I have the best definition for that. I probably should add it to a slide somewhere. But if you have an identity that is consistently stigmatized, marginalized, you're going to experience each of our systems, our institutions, in an oppressive kind of a way. So an example, sometimes, actually, let me use an example a patient had brought to my attention. It didn't affect her family, but what ended up happening was a young child, kindergarten-age child, who was from the same immigrant community. So they were all identified as Black. The child was acting out, and the teacher ended up physically putting this child into like an isolation room without notifying the family, and did this repeatedly to the point that actually the behavior was escalating and wasn't actually addressing the root of the problem. And so for that family, the education system wasn't actually meeting their child's needs, and that would have been experienced as an oppressive kind of experience for that family. So hopefully that kind of off the top of my head example helps to illustrate what we mean by when we're talking about anti-racist and anti-oppressive. And when we're talking about healthcare, this is my kind of from my brain onto the page. We're thinking mostly right here, we've been talking about healthcare delivery, but I also wanted to reflect on two other sections, which are education and then representation and leadership. So one of the things is addressing misrepresenting race and the role of medical schools in propagating physician bias. And so it didn't come up, I think we had it in some of the slides that we trimmed out, but there's an often referenced study where they surveyed medical learners on their opinions and perspectives about the experience of pain of people of different races, and where these medical learners in the United States, their bias was that Black patients were going to be experiencing less pain and therefore needing less pain medication, like on a consistent basis than white patients. And so looking at how do these biases develop in medical trainees and how do we address them. This kind of touches, have you seen this study, Ziad? I don't mean to put you on the spot at all, but this hits the nail exactly on the head of what we were talking about before about the language. So this was by colleagues, some of them from Johns Hopkins from the Sickle Cell Clinic. And it's entitled, Do Words Matter? Stigmatizing Language and the Transmission of Bias in the Medical Record. So some of it was when we're reviewing cases and the language we use when we're discussing patients. But then also there's this enduring record that lasts of whatever anybody says about the patient, especially if you have an EMR. I don't know if everybody does, but especially if you have an EMR and whoever writes the first note, and then if that gets copied forward, right? Like literally cut and paste forward into notes. I don't know if anybody's seen that. I see it, unfortunately, a lot, like for all kinds of things. Sometimes it's just a mistake in the facts, but sometimes it can be stigmatizing language. So cutting to the chase, I encourage everybody to seek out this paper. It's a really good eye-opener about how subtle changes in the language we use can influence bias the reader about the patient. So I'll try my best to describe what they did. They had 2 different descriptions of the exact same patient, and then they had medical learners, I think it was residents, read it, and then give, like on a Likert scale, their impression of the patient, whether they had positive or negative impressions of the patient. So I'm going to read this really quick. On the neutral language chart, it's Mr. R is a 28-year-old man with sickle cell disease and chronic left hip osteomyelitis who comes to the ED with 10 out of 10 pain in his arms and legs. He has about 8 to 10 pain crises per year, for which he typically requires opioid pain medication in the ED. At home, he takes 100 milligrams OxyContin BID, oxycodone 5 milligrams for breakthrough pain. Over the past few days, he's taken 2 tabs every 4 to 6 hours. About 3 months ago, he moved to a new apartment and now has to wheel himself in a manual wheelchair up 3 blocks from the bus stop. Just factual, right? And then the one on the right, they termed as stigmatizing language. So let's read through. Mr. R is a 28-year-old sickle cell patient, so versus man with sickle cell disease. It's pretty subtle, actually, with chronic left hip osteomyelitis who comes to the ED stating he has 10 out of 10 pain, all up in my arms and legs in quotation marks. He's narcotic dependent and in our ED frequently. At home, he reportedly takes 100 milligrams OxyContin BID and oxycodone 5 milligrams for breakthrough pain. Over the past few days, he says he has taken 2 tabs every 4 to 6 hours. About 3 months ago, patient states that the housing authority moved him to a new neighborhood, and he now has to wheel himself in a manual wheelchair up 3 blocks from the bus stop. Really subtle stuff, but saying stuff like the patient said, it's like he claims this. He says that, saying that he's a sickle cell patient rather than a man with sickle cell, really subtle. And the outcome of this was that there was a statistically significant difference in the impressions, whether the learners had a positive or negative impression of the patients. So, wow, it feels like a big responsibility, right? Yeah. Please, yeah, and I'm just talking, so yeah, interrupt me.
I just wanted to ask a question then, because it's come up again that we are supposed to quote everything somebody else says, because it came up in the actually court of law where they said, do you know for sure?
Yeah.
Did you know it? Did you see the learner ask that? For example, did you ask them exactly that question yourself? Same thing, right? Like, so I was always taught that you quote what a patient says because that's their story, not your story. So you could say, as per the patient, or history as per the patient, and then write something on the thing, but these are not your words, these are his words, right? And so I was always taught that was empowering the patient, even though it does sound quite derogatory when you read it like that, right? So I don't know legally how it would stand, because are you sure? Were you at his house, doctor, to tell me that he took this, right?
Yeah.
So I think that's where, because I've talked to a couple of pediatricians who are recently in court for things like this around learners, and reading the learners' charts with Connect Care Epic, and the way that the charts are now put forward. So, but I totally see the point. Is there a different way to use the language so it's more medically safe for us as well? Because it's
a really good question. And interestingly, though, this study happened in the United States, where arguably things are, tenfold more litigious than in our setting. So it would be interesting to hear maybe from a CMPA lawyer or something about their impressions of that. I think it's implied that when you're taking a history, like it's implied that the source of information is what the patient's telling you. Yeah.
How I counted it is put before everything as per the
That's a good one.
and I just write
Yeah.
the story, right?
Yeah.
Or
Yeah, that's a really good.
right, whatever it is, because that's
Yeah. And just 1 second, Kevin, what you're referring to is where then the attending hasn't heard the words directly from the patient and is saying, this is what the patient.
signed off on the chart.
Yeah.
Co-signed
I
the
see.
chart, right? But
Yeah.
Did you take that history? No, I
Yeah.
didn't take that history. I got a second.
Yeah, so in some ways that's maybe even a little bit extra, like a little bit different and another layer.
I
Yeah.
this.
Yeah.
But, and I think it's implied, but I mean, that was my own caution.
Yeah. Thank you.
Make sure we know where the words are coming from, because
Mm-hmm.
at least you guys can think of
Mm-hmm. Thank you. Thanks, Aisha. Yeah, Kevin.
I think it depends on why you have to quote the patient.
Mm-hmm.
I mean, to me, that's not necessary.
Mm-hmm.
I mean, like, you sound like a dick, right? When you quote the patient like that. You know what I'm saying? Like, yeah, yeah, exactly, yeah, exactly. You see, all they have to change is patient states that his you know, the pain is at his arms and legs.
Yes.
That's all.
Yeah.
From from shoulder to fingertips.
Yeah.
That's all you have to say if you want to be that specific, right? Is what is necessary and what is not. I mean, the only time when I would quote the patient is if the patient is expressing an opinion about a medical issue. Like, meaning that, yeah, go ahead.
No, go ahead.
Yeah, it's when, say, when I render a professional opinion and the patient is at odds with my professional opinion and they have their own views, and I will quote that. Yeah.
Thanks, Kevin.
Yeah, that's when I would quote patients.
Did you have something to add there, Irabana? Yeah. Do you want to take the microphone? Kevin's got the microphone for you behind if you want.
Thank you. It's similar to what Kevin was saying, because you know, I agree with, you know, the, I guess, precariousness of quoting a patient, but when you see what they chose to quote, you can see that they're trying to tell a certain story. Yeah, they're trying to tell a specific story, and I think you can probably mitigate it by what you've described, like as stated by the patient, or, but you know, just simple things like Madeline pointed out, like describing the patient as their disease, you know, the individual as their disease, a sickle cell patient, and that they're narcotic dependent. You know, the language is just so negative. But,
Don't say narcotic dependent. Just say patient is currently using 350 mg per day.
Yeah, so none of that is.
So that tells the entire story.
So yeah, I would encourage everyone to take a look at this paper. It's interesting, and the discussion is quite rich as well, just kind of thinking through. It gives us, we don't want to overthink, we don't have time to, you know, thinking that system 1, system 2 thinking when we're trying to make diagnoses and things. Similarly, we can't ponder every word that we're gonna, but we can start to get into good habits that you know, another thing I sometimes think about is if the patient was reading this note, how would they feel about the interaction? Would this build trust? Would this build their trust in me? Or is anything I'm saying here or framing it in a way that would be minimizing their trust in me? Yeah. Yeah. It's kind of giving that flavor. Yeah. And what's been really interesting for me, I've been in a role unrelated to my clinical role, a consultant role. I've been reviewing charts from around the world. And it's very, very interesting to read the language that people use and to try to picture, therefore, the kind of treatment that the patients had by those providers. It does give you a feel of whether the person, you know, truly feels a sense of caring toward the patient or not, for better or for worse. Yeah. So when we think about education, part of it is educating ourselves and the people we're working with about doing all we can to try to minimize stigmatizing language in the chart, with each other, etc. This is just an example of stuff I've been involved in Hamilton. Irabana's been doing amazing work in Ottawa and beyond, thinking about you know, anti-racist medical education and the need for diverse perspectives. So education out in the community, but also bringing patients and community members into the education. So this wasn't specific to sickle cell disease, but we did a series of education sessions for our Department of Medicine, for the Department of Pediatrics, and now it's embedded in the medical school curriculum at McMaster to have a session on anti-Black racism and Black representation in healthcare, and it's part of the annual. Just today I got an email, can you? And it's this coalition of 4 people on the right-hand side, or 8 people rather, on the right-hand side, whose voices are all coming together. One of whom's a social work professor, one of whom is my friend Lyndon, who I mentioned before, who's a community member, a social work grad student, and a whole bunch of physicians representing different specialties and life experiences. And so then actually jumping off of that is the representation that's needed in healthcare and in leadership. And it's interesting, Vicki and I had this conversation, and Chantel, who's in with the nurses now, of just like on our medical teams, if we're providing care for Black and racialized patients, what do our teams look like? When they look at the team, do they feel like their experience in life and their perspectives are represented or not? Should we be mindful of that? Should that be the only thing we're thinking about, or actually are there so many other things, and how do we think that through? So I don't have any answers, but it's something for us to be mindful of, especially when we see research coming out, again, American research, but most of what happens in the United States applies equally well here. Better outcomes for Black patients when they have Black doctors. And I've oversimplified the answer here. What's the difference? Probably all kinds of things are the difference. But I think fundamentally that aspect of listening and trust, but bidirectional trust, is the physician trusting what the patient says? Is the patient trusting the physician? And, is that therefore a healthy, fruitful physician-patient relationship? It's not to say that race is the only thing. I feel like I try to develop good trust and listen very well to all my patients, regardless of race or other intersecting aspects of their identity, but it gives us pause to think about and kind of spurs us on to try to support initiatives that help to increase the diversity in healthcare and in our teams. And so this is my last slide. We've talked a lot about what needs to happen at that micro level. So our patients, their families, how we can help to provide excellent care for them and actually help to wrap around and assist them with any challenges in their social determinants of health that are impacting negatively on their health and on their healthcare experience. I think, we all have opportunities, and some of us, maybe more than others, where we're living, what our roles are, and how much time we have. But for me, it's been really rewarding to seek out opportunities within the community to help to work on anti-racist initiatives and with other healthcare education. I think we all have opportunities to even work beyond that, right? Regional, provincial, national, and here we are as CanHaem. And I'm really proud that CanHaem early on in the pandemic came out with a statement after George Floyd was killed, came out with a statement about how structural racism can't be tolerated, and how we as an organization are collectively working to combat systemic racism. So this is within our scope as an organization, and sky's the limit, right? We can always aim to support international initiatives on this front. So with our remaining minutes, I'm sure some of us from the East Coast are probably starting to feel ready for bed, especially after using our drink tickets. But any energy that folks still might have to reflect on any of that, to reflect on our experiences as healthcare providers working in these spaces, to challenge any of these ideas or wrestle with, but what about this? You're making this also sound so simple, but it's not always that simple, right? Because it is in those challenging or uncomfortable situations that we all grow. So this was just kind of like a partial listing of stuff. Oh, these guys are wrapping up too. Partial of listing of some of the things that we thought might prompt thought. And I don't know if Irabina's having her last bites of cheesecake. We've got this, we tossed this very big term at the bottom. Do you want me to try to explain it? Okay. So I have a screenshot, I think, here. So I got on Twitter a few years ago, and I'm kind of hot and cold with it, but I find it to be a really cool way to hear diverse voices and perspectives. And so on my Twitter, I follow a lot of people who are working in the anti-racism space, especially in healthcare. And this is a colleague from the United States, Tamora Lewis, who, this is a couple years old already, where she's got this really brilliant thread where she highlights how racism manifests in healthcare very insidiously. So she terms it cumulative deprioritization. It's a big mouthful. And I'll try to like paraphrase this thread that she puts here. But she talks about how healthcare spaces are really busy. There often aren't enough resources in the moment to deal with all of the needs of patients. And I don't know how other provinces are right now. In Ontario, healthcare is in a bad state because of staffing and funding and all the rest. And so she's just got a series of examples where the resources are limited, and she says if there's 3 patients, who gets that resource? And sometimes the resource is time and attention. And she explains, if there's a family who are questioning and skeptical and feeling a lack of trust in the team in one room, and they happen to not look like you, and then there's a family who's smiling and pleasant in every interaction, and they happen to look like you as a nurse or a healthcare provider, who might you be more inclined kind of instinctively to spend more time with? And you might not even notice it, right? So it's just this kind of idea. And then if you multiply that by some of our patients, I'll say with sickle cell, they might come to the emergency department a dozen times or 100 times, or heaven forbid over their lifespan 1,000 times. And so if this is even happening like 1/10 of the time, what is their cumulative experience with the healthcare system as compared to somebody else who's doesn't have that mixed identity of the sickle cell and all of the stigma and everything from that circle. So So we threw that term on there, but I guess it required explaining it. Do you want to come up here, Evana, in case there's any kind of points or discussion or questions that people have? Oh, yeah, okay.
I just have a question about the notes, because I think as more and more provinces are moving towards electronic medical records with that copy and paste and propagation of those notes, are any facilities, the people around the room, actually doing audits and trying to pull out aspects that would reflect some of the systemic racism or inappropriate kind of way of notes kind of going through? Because if that's being propagated and it becomes your cultural norm within your EMR and nobody's shining a light on it, it's just going to continue. And as you say, patients in many provinces are seeing all of those notes as well. So is that just extra weight on top? But I know we're not doing it in Alberta yet, but I do wear a hat for medical informatics, so that's something that I think could potentially be done. But is anyone else?
It's a great opportunity. I'm not aware, so we're both in Ontario, opposite kind of ends of southern Ontario. I'm not aware of anything like that happening, but you're right, with medical informatics, the sky's the limit in terms of analyzing that. And at our hospital, we've got, as many hospitals within EMR probably have, we have a physician audit and feedback program where we've got kind of a team that's looking at more objective things, though, like did they transfuse 1 unit or 2? Did they do CBCs every day when somebody was in the hospital, even though the hemoglobin was stable, those kinds of things, and then providing feedback to the physicians so that they can improve and try to meet best practices. It's not a way to try to snoop on physicians or get anybody in trouble. It's really that kind of intention to give them feedback. I could see this being something similar. It'd be interesting to, I'm not an informatics person, but it would be, if anybody was so inclined, it would be, I think, a really great opportunity to help improve best practices for the notes. Yeah, I don't know if you wanted to add anything.
Sure, no, I agree, because so at CHIO and at McMaster, we're using Epic just like you are in Alberta, and I think that there's an opportunity there because, we've been told that Epic is so powerful in terms of the data and analytics and the potential. Yeah, so I do think it's an opportunity, and with AI, the sky's the limit, as you're saying. So maybe it's potentially a study or potentially a tool that could be leveraged. And then I guess in the same vein, I know that at your hospital and at CHIO as well, we're talking about ways to try to collect race-based data as another way to get a better understanding of the impact of racism on patient care or structural racism on patient care and outcomes. So I think if we're able to incorporate that into our EMRs and information systems, I think we can get a lot of valuable information and make some like positive changes too. Yeah.
I was just going
So-
to say, oh, sorry.
Go ahead.
So one of the things that I think will also change things is patient access to data. So I know that most of the provinces now have systems where patients can look up their own blood results or investigations, but I know that at least in Saskatchewan, they're moving towards a system where physician notes will be on that system, so including kind of consults in the hospital, including admissions and discharge summaries. And so I think that that's when it's going to be even more important that our wording is very specific when kind of patients have easy access to that. So yes, now they have access to that, but you have to request your chart, and it's usually a process, and not very many patients go that way, whereas everyone's looking up their, not everyone, but I think it's 37% of people are looking up their own blood work and things like that. But for them to have easy access to those notes means I think that we're going to also have to be even more careful about exactly how we're wording things.
I think the best way of learning how to word things is actually to talk to the patient. For example, this is one thing that really surprised me. We talk about disease burden, right? And a lot of my patients with sickle cell disease, they don't like that because they feel that they are burdened to themselves, they're burdened to the family, they're burdened to the society, etc. So I went to the Thalassemia Foundation and I said, because I think we were developing I don't remember, guideline or something. I think it was about, describing new clinical trials and how this potential therapy can reduce disease burden. But I want to change that term because it was stigmatizing to patients with sickle cell disease, and I thought that maybe the same thing would apply to patients with thalassemia. So I spoke to them and they said, no, keep that term. We don't feel that it's stigmatizing because it is truly, to us, is truly burdensome having thalassemia, being on inoculation and transfusion. So I think speaking to the patient is most important, getting feedback from them, as opposed to saying blanketly that this particular term is a no-go, or this particular method of framing your notes is the right way or the wrong way.
So I find that conversation really interesting just because one of the conversations that I found quite enlightening a few years ago that I had with one of my patients who's actually quite active in the Sickle Cell Saskatchewan group is that he had that they actually don't like this family really didn't like us calling it sickle cell disease. And so one of the things that I've been very specific about doing since then is say sickle cell anemia and actually leaving the disease part out of it. And so I think it's some of those subtle things sometimes that that I don't even think about, and probably all of us don't think about, that even when you're doing education with the patient, that can have an impact.
Yeah, personally, I've found, I think in my notes, I probably still use sickle cell disease consistently, but when I've noticed when I speak with patients, I just say sickle cell. I've started to get away from using the word disease because I've repeatedly got that feedback from many patients as well. So I saw one patient organization just trying to change the terminology and started calling it sickle cell disorder, which, I guess maybe we want to think as a global community of whether we change it, but I guess those of us who want to kind of keep things properly categorized and following consistent language in medicine, that might be a bit trickier. But like thinking about on the individual patient level, and then I guess kind of thinking on the systemic level, are we comfortable using that word disease? Yeah.
Yeah, similar to what Dr. Sinha was saying. I'm Riley, I'm a medical student. Dr. Sinha is my supervisor. And you'll actually hear it in my presentation tomorrow for the research that I did. But initially in my presentation, I say, sickle cell disease this. From here on out, I'm going to refer to it as sickle cell anemia because this is what our patients and their families prefer when we talk about it. And that really changed for me. I started the project doing a literature review. So I'm looking at like, okay, like what are all these articles saying? And I'm like, okay, well, I hear we talk about it as sickle cell anemia when I'm talking with Dr. Senna and with the group and stuff like that. But in all the articles, it's like sickle cell disease, sickle cell disease. And so I'm looking, and it's like, it got very technical. Like I was looking into it, and it's like, oh, well, sickle cell disease because it's a group, right? But then none of that matters when you're building that trust with the patients and their families. So it was just interesting how quickly that changed, and it changed because of going from having not met the patients and their families yet, just looking at the literature, getting to meet with some of the families, getting to meet with the group, and that like immediately, now it's sickle cell anemia. Yeah.
I don't like the term sickle cell anemia. So personally, it doesn't reflect the process or disease process disorder the patient has, right? Necessarily, because we group people who have SC and S beta plus with that, and that's where the term originally comes from, is the sickle cell anemia is S beta 0 or S beta null and SS, right? Versus the other diseases. But I think, and so that's why it's separated medically, but I think with a patient it's quite different. And I can see how you're referring to patients with sickle cell. It's probably easier for them with that term rather than actually putting anything at the end of it, because it really doesn't matter. And a lot of our patients aren't anemic anymore with Hydrea, which is quite nice. I was going to ask you a really funny and unusual question, but it came up in a discussion we were having in clinic actually the other day, because race often comes up in clinic. We have a very multiracial clinic in terms of healthcare providers. But what the term racism actually is now. So the medical student said that it was about systemic, like almost what I would have described as systemic prejudice or bias, whereas I always thought it related to race. And they said, no, it has nothing to do with race. So, well, okay, thank you. We got into this big discussion about it in clinic, and I was like, okay, I always thought race, that anybody could be racist because it's based on your being prejudiced against a race, right? But they were telling me, no, that term has changed, and now it's not like that. So I just wanted clarity, because I honestly was just confused by the end of the discussion, and
and maybe on the microphone so that the virtual folks.
So some of where they might be coming from, and just like I took a sociology class, and like this kind of came up. Okay, so from my understanding, limited understanding based on this sociology class I took, is just that like I think just defining, I guess, race, and how like sometimes in the past people would define race as being something very specific, like genetic, like, okay, so this is specifically your genetic, so you are this race, whereas like race becoming more in sociology terminology as like a social construct of like what we're like how groups of people can become racialized, but it doesn't, like, there aren't necessarily specific like genetic things that like make one race one race.
Race has no genetic.
Right.
Exactly.
Yeah,
I think that's what they're
I
think that's what they're saying is like there's no genetic basis in it, and so that's how the term has changed maybe.
But what is the definition you guys are using for racism? Because I just want to be clear that I'm talking about the same thing, which would be
Prejudice.
based on race.
Right, a prejudice or a bias based on race. And so it's interesting. I mean, like, from my perspective, racism can exist at many different levels. So, you know, for an individual, based on how you, the beliefs you associate with a specific race, so that your personal beliefs are your individual level racism, but the way you enact those beliefs with another person, that's interpersonal racism, and then there's institutional racism, then there's structural racism. So I feel that, you know, as you get broader, there are different levels. So I wouldn't agree that structural or systemic racism is the only type of racism, because you can be racist on an individual level. So like, it's the first time I hear that. Yeah, it's interesting. Yeah.
Another
big discussion, because a lot of the people were saying, well, I can't be racist because I'm whatever race.
okay, I was just gonna say kind of from this same I was just going to say from this same thread. Yeah, and I think just and I'll just mention it, and if you want to add anything, Ravana, but in this same thread, I think the last tweet is Dr. Lewis saying that even though she identifies as Black, she has grown up in the racist environment of the United States, and she continuously needs to check her own internalized racism, as a result of the environment that she has grown up in, right? So again, just emphasizing that no one is immune to racism, and it's kind of coming back to that system one thinking, like you kind of get programmed. I think about it, and I don't know if it's a crazy thing to mention, and I'm dating myself, but I grew up when the TV show Cops was on all the time. Again, this is like an American setting, but it would often be police of whatever races they are, but probably mostly white, chasing Black people through the streets, a lot of times for whatever, drug crimes and things like that. And if you're seeing that over and over again, white cops chasing Black perpetrators, right? Like it imprints on you in some way, right? And if that's a consistent theme in movies or in media, you're gonna internalize that whether you realize it or not. I didn't ever even watch the show, but just from surfing the channels. Yeah, so I don't know if you want to add or.
Yeah, it's interesting, and it's true that like these beliefs, these storylines start from a very early age, and I really believe. Sorry, I believe that storytelling is a really powerful tool, like in general in teaching, and another more personal story is one of my daughter when she was 4. So she started talking about race when she was probably like 2.5, 3, when she started to notice the differences between her skin color and her friend's skin color. So my daughter is of mixed ethnicity. I'm of Ghanaian descent, and my husband's of Indian descent. So if you ask Nalia, I'm Black, Daddy's light brown, she's brown. But when she was 4, she came home one day and she was really sad. And so I asked her why she was upset, what happened at school. And then she went on to tell me about how she was coloring. And for her, she colors princesses to look like her. So her princesses were brown. And her friend, her BFF at the time, who happens to be white, turned to her and she said, "Why are you doing that? Brown's not pretty." So, it turned into a conversation and an opportunity to teach about a little bit about race and racism. And then I actually reached out to the parents and talked to them. But anyways, that's more detail. It actually had a very positive outcome in spite of, the very negative beginning. But it just really reinforced to me that what, like Madeline's saying, we're not immune. And even from a very young age, you start to form those biases. And so you really have to work hard to overcome them, because society has already decided how they place people in boxes, right or wrong. And so we really have to consciously break down those categories, right? And it means that we have to teach our young ones to do that too from an early age. So yeah. That's great. Yeah, Ken.
I'm gonna raise something very controversial
and existential. And it stems from my experience with.
Some more wine.
Huh? I haven't even started. I still have my 2 tickets. So I want to tell you a story first, and I want to bring up what was controversial about it. When my wife and I, my wife is Irish, I'm Chinese, obviously. When we raised our daughter, we never, talked about skin color. We never talked about anything. The first time she ever identified someone by skin color was merely to tell the difference between 2 friends who had exactly the same name. And one of the friends was African descent, and she used the term brown, actually not Black. So, because she has no concept of calling Black people, white people, orange people, whatever, right? Identifying people by color. So she has no concept of that. So my controversial question to all of you is, by making these sort of emphasis right now that we're doing are we then perpetuating these classifications? Because ultimately, I think what we want to do is to break down these classifications completely such that they don't even exist to begin with. That we don't classify people this way. Because just the act of classifying people based on their skin color or based on their race implies racism to me.
Yeah. And so, okay. Sorry, go ahead. No, it's okay. No, I totally agree with what you've put forward. And it's interesting because in our home, we don't necessarily talk about race either. And it's interesting because the first time my daughter came to say I was Black, it's because she heard it from a peer. And so the ideal, and I think the success of EDI would be when we get to a point where there are none of these boxes and we're just all people, right? But I think that the challenge is those boxes exist already. And so I think that in trying to teach our children that they're meaningless, in that, you know, being in a certain box shouldn't come with a certain privilege. Like, I think that's the way we'll undo it. But I agree that, you know, the ideal would be that there wouldn't be these categories. Yeah. Mm-hmm. But yeah, it's not easy.
Oh. I just want to bring attention to the bias of this discussion, which is talking about race. I mean, obviously, in the context of CanHaem, we're going to talk about race and largely the experience of African people. But the 900-pound gorilla of racism in Canada is the experience of Aboriginal people. That's way the bigger problem. Way the bigger problem.
And yes, so I think that's really important to acknowledge. And, you know, as we tried to say, we aren't trying to diminish any one group's lived experience. And I think it's important to acknowledge that, you know, as, you know, trying to start more broadly with social identity, it's firstly not just about race, but when we're speaking about racism, it's not just about one particular group. But I think the general principles still are valid. Yeah.
I wanted to add, I'm not sure how long we're going for, but I had a comment that I think in the Quality Standards Committee it came up that should we call it anti-Black racism or should we call it racism? You know, what are we dealing with? This was the it came up, and I don't know what the resolution.
We called it both.
I know exactly. We called it both, and that was the, you know, sickle cell disease quality standards. It was very specific to, you know, the vast majority is anti-Black racism, and then the other piece we deal with a lot in our clinics is, you know, the thalassemia patients. The vast majority are not, and the big thing there I find in my clinic is the minimization of the need for a translator. It comes up often where it's like, oh, well, you know, we're in a rush, so let's just, I speak Arabic, so they charge me with like translating for the social worker. Like, we need to get a translator for you because we have different roles. So it's, you know, there's a lot, I think a bigger discussion. I think the vast majority is, you know, a vast majority of the racism that's happening is against the Black patients. But I think we have to suss out that language, figure out what should we use altogether.
Yeah. Just to that second point, and then coming back to the first point, I wanted to highlight that as well. Just that intersection of identities. So Irabina talked about it a bunch in the beginning, but like thinking about practical applications to our patients. So I think patients' socioeconomic status and class, so kind of classism. If someone's an immigrant or what language, as well. Many of our Arabic patients are Muslim, and the women are visibly so, and Islamophobia that comes in as well. So yeah, I really appreciate you highlighting that. We focused a lot on sickle cell disease and the fact that the bulk of the patients, and again what Dawn was saying as well, we tried to weave some examples of anti-Indigenous racism in hemoglobinopathy, specifically in Canada. That doesn't come up typically as often, but it's great that and important that each one of us is tuned into all of those, because I know many of us wear many hats, right? And we're not always just interacting with patients with hemoglobinopathy. It's folks from all walks of life, right? Did you want to add? And then Aisha had the mic as well.
Sure, and so thank you for that. And then just to address your question about racism versus anti-Black racism. So I think it's an important one because there are general principles that I think apply to different groups. But in thinking about anti-Indigenous racism, for example, or anti-Black racism, a lot of the racism comes from historical legacy, right? So that's something that's really important in contextualizing the causes of racism and identifying solutions, right? So I think that's where it becomes important in specifying the specific type of racism. Yeah.
I think why this is so pertinent to hemoglobinopathy patients, it really comes down to the fact it's about, to me, a lot of it's about resource allocation. How do we allocate resources to patients across the board? And we, at least in peds hemonc, we treat oncology patients who get everything, absolutely everything, all their outpatient meds, everything paid for. They get car rides to the hospital, you name it, everything's paid for, whatever their socioeconomic status is and whether they need it or not. Whereas all our other patients, be them hemoglobinopathy or not, get nothing paid for, but the hemoglobinopathy patients have a high burden of medications, of hospitalizations, of all of these things, blood resources, these sorts of things. This is really why I wanted to highlight it. It's because it's that disparity in care that we are delivering. And I think COVID really highlighted that for me as well. So we had this lockdown period in the hospital, at least at our hospital, where nobody could come in or out. So a mom would be at the bedside, not allowed to leave really, and they wouldn't serve halal meals, for example. They wouldn't, so they weren't feeding the parents for one. They're not allowed to leave the room. But then they didn't, and then the mom wouldn't eat, and they'd be like, well, she's refusing food, she's too picky. And it's because nobody bothered to ask her that she needed a specialized meal. And my patients, almost all of them, come from Africa and come from different religious backgrounds. And they also don't want to be rude. They don't want to, this patient didn't want to be rude and didn't want to impose upon the healthcare professionals. She didn't eat for 48 hours, this parent. And at door screening, they would get harassed, a lot of the patients, whether they were Indigenous. And then when I spoke to the screener, we asked a set of questions. I'm like, can't you understand why the mother of the 2-year-old wouldn't want to leave her child at the door when she's bringing her 8-year-old to the clinic? And they're like, well, we're going to leave them with somebody she doesn't know. Would you leave? You're in a new culture, in a new environment, in a new city, and you want this single mother to leave her child at the door. And they would be like, well, she can't come to clinic. Until half the nurses went down from clinic. Everybody was in tears, and everybody came back up to clinic with the mom and the multiple children, because we just ended up booking the sibling into clinic in the end. But that shouldn't have to happen. But it really highlighted the systemic barriers that our patients face. And this happened. I had 3 complaints of racism, 1 from an Indigenous family and 2 from sickle cell families, for screeners, and that they say, oh, we run a script. And I'm like, which script isn't working? Because there's something wrong with the script. We've screened it for racism, obviously not well enough. So I think these things are kind of highlighting, and that's really why I think Robert and I had talked about this at our strategic planning event, that this is a key topic for the patients that we serve, and bringing this to the forefront and trying to get resources for these patients in general is kind of where we need to work, with knowing that they have all the barriers. So I just really wanted to thank you too, because you really set the stage well for tomorrow. And we have a couple of, actually every conversation that we'll have tomorrow, and a lot of them will be panels, are based around trying to integrate how we increase access to care for a patient population that for whatever reason has experienced a lot of bias within our society. Maybe it because it was relatively rare a long time ago in, say, Alberta, and now it's quite common, and yet the resources haven't reached it. So somebody talked about deferriprone and not being able to access deferriprone. They had leukemia, they get their medicines.
Hydroxyurea, even before, not everybody has covered hydroxyurea.
We don't have hydroxy coverage in Alberta.
As a really brief aside, I'd like to say, as an Indigenous woman, I'm Saulteaux, Métis, Anishinaabe, and I'm a proud band member of Pine Creek First Nation in Treaty 4 territory. I feel empowered just sitting here in this conversation, and I'd really like to thank the both of you. Like, it's awesome. Like, no matter the particulars of what we call it, the similarities, the differences, I'd just like to thank you. Yeah.